and thank you for joining us for today's session, FAQs on multiple myeloma following relapse after 3 or more lines of therapy. I'm Mary DeRome, Senior Director of Medical Communications and Education at the Multiple Myeloma Research Foundation. I am joined by Dr. Sandy Wong from the University of California at San Francisco, Ms. Donna Catamero from the Mount Sinai Health System in New York City, and Mr. Stan Wagner, a patient from Brooklyn, New York. They've been gracious enough to agree to spend an hour with us today to answer some of the frequently asked questions we receive from patients and caregivers about what to do and what it means when their myeloma comes back after a response, especially when they have previously received multiple lines of therapy. Last week, we hosted a webinar on this topic, and we received more questions than we could possibly answer during that time. So hopefully we can get more of your questions answered today during this session. So Sandy, I'm going to put our first question to you. And the question is simply, why do myeloma patients relapse?
Well, that question is actually not that simple. The reasons for myeloma relapse are actually really complex. Generally, it's because the myeloma cells have found a way to resist the treatment that we're giving the patient. The mechanisms by which that happens really depends on, what drug the patient is given at that point of relapse. Like, for example, if patients relapse through Carchy treatment, it's been shown that some of those relapses is because loss of the target, a loss of the target on myeloma cells. So it really depends on what they're being treated with. And that determines why they are relapsing. But it's unique for every patient.
Yeah. Okay. So now let's talk about how patients know that they've relapsed or have become refractory to their current treatment. So Donna, I'm going to start with you on this one.
Sure.
Which tests should patients follow to be aware of potential disease recurrence? Or to put it another way, which test results that you receive would indicate that the patient needs to be put on a different therapy?
Okay, so there are several tests that we use to monitor patients throughout treatment to see how they're responding. And these can be individualized depending on what type of myeloma a patient has. So the first test is a serum protein electrophoresis. So we know that in myeloma, myeloma cells produce a monoclonal protein. So healthy individuals won't have any monoclonal protein, but myeloma patients will produce up to several grams of monoclonal protein, and this is what we call an M spike. So we monitor patients' M spike. There's certain patients that don't produce an M spike. So again, it depends what type of myeloma you have. Another test is quantitative immunoglobulins. So this test will detect maybe excessive amounts of immunoglobulin, and depending again what type of myeloma a patient has, so IgG or IgA, we can measure the excess amounts of this immunoglobulin. And then another blood test we look at is serum free light chains. So for healthy individuals, our plasma cells will make both heavy and light chains, and together they bind and form your immunoglobulins. But in myeloma, some myelomas will produce an excess amount of free light chains. So this is a test we can measure the extra amount of light chains, and this is either going to be a kappa or a lambda. So for patients with straightforward myeloma, we can measure an M spike, an immunoglobulin such as IgA or IgG, and a free light, so kappa or lambda. So there are other tests beside blood tests that we look at. So imaging is another source of whether a patient is responding or not. So we like to do either PET scans or MRIs, and this can detect new bone lesions in the bone marrow, plasmacytomas, which are soft tissue masses produced by the plasma cells, and this can occur anywhere throughout the body. So we like to image patients every 6 to 12 months, depending on if they have pre-existing disease that we like to follow. And then finally, everyone's favorite test, bone marrow biopsies, which are really important. So if a patient is actually having a great response and we suspect complete remission, we like to do a bone marrow biopsy to see if there's any residual disease. So this can help us confirm a complete remission. Also, at a time of relapse, we like to do bone marrow to measure the percentage of myeloma cells or plasma cells in the bone marrow. And then I know we'll discuss later, but we also like to look at the genetics of the myeloma, and this can tell us how the disease might act.
Well, so that's quite a list of tests, and people have a lot of choices, right? So, Stan, I'm going to go to you for this one. Can you tell us what it was like when you relapsed, and did you keep track of your lab values, or did you physically feel like you were relapsing?
I've been tracking my values since day one, to the nth degree, and I was in complete remission probably for 5.5 years since the induction therapy. And then I noticed my M spike which was 0 for all those years, going to like 0.1, 0.2. And then I had my visit with the doctor, and he said, well, it's time, you've relapsed. And I, for some reason, ignorantly said, oh, let's just up the maintenance dose of Revlimid. And the doctor said, no, we have to change everything up. And so it's a new regimen.
Yeah. So, and these are the decisions that become difficult, right? So when you relapse,
I mean, it's difficult, but you got to do what you got to do.
You do. Okay, Sandy, we're going to go to you now. We've had several questions from the webinar about chromosomal abnormalities. So can you explain the importance of testing for chromosomal abnormalities?
Yeah, so testing for chromosomal abnormalities is really important in multiple stages of the disease. Obviously, when you're first diagnosed, it feeds into the revised ISS staging system. So it really helps us, give an idea of what this patient's journey with myeloma is going to be like. And that's how we think about, prognosis and risk. Is this the garden variety type of myeloma, what we call standard risk, or is it intermediate risk, or is it kind of sneaky and considered high risk? So, that's the first time we really test for it. Now, for patients who are in relapse, oftentimes we do repeat a bone marrow biopsy to reassess their cytogenetic risk. I think that's especially true for patients who are standard risk to start with, because when they relapse, they may gain other chromosomal abnormalities that tells us, hey, like this myeloma has gained new, sneaky tricks, and it may be more resistant now to the treatment that we have. So I think especially for standard risk patients, we want to reassess the chromosomal abnormalities and say, hey, did the myeloma cells change? Like, for example, if a patient was standard risk and then on relapse, we did a marrow and found out that they had, for example, deletion 17p or amplification 1q. Those are classic high risk abnormalities. Then we think, when we select our treatment regimen, we need to be more aggressive, number one, and number two, sometimes just because you relapse by labs alone, some patients we talked about, Donna and Stan talked about just relapsing by labs alone, and not having any symptoms and feeling okay. Sometimes those patients, after talking to their doc, sometimes they're like, what, doc, can I just stay off treatment for a little bit longer? And if they are still standard risk, that may be okay with very close monitoring. But if someone who is high risk, you really don't want to wait, and you want to just go ahead and start treatment, because we really want to gain control before the relapse starts to hurt the patient. So that's all really important. And then no discussion about chromosomal abnormalities could be complete without talking about translocation 1114. Translocation 1114 actually is considered standard risk. However, as patients, even standard risk patients, as they relapse and go through different lines of therapy, when the therapies when the list of available agents starts to decrease over time, then you're looking for other therapies to treat the patient with. One of the things that we can consider is using a drug called Venetoclax. Now, this is a drug that's not yet approved for myeloma. Any use of this in myeloma will be considered off-label, but there have been some studies showing that Venetoclax may be efficacious in those patients with this translocation. So in a nutshell, yes, chromosomal abnormalities are very important, and they sometimes need to be reassessed.
Yes. So you did answer another question that was submitted, as in whether the chromosomal abnormalities can change over the course of a patient's disease. So you answered that. Yes, they do. So, and in some cases, is it the chromosomal abnormality change that actually causes the relapse that patients experience?
Yes and no. So sometimes if a patient relapses and we check and we go, oh my goodness, this person has like a new chromosomal abnormalities, let's say it's deletion 17p, that would explain why the relapse is so brisk and see the numbers really rise really quickly over time. And you wouldn't expect that of a standard risk patient in relapse if they didn't acquire anything, any special, if the myeloma didn't acquire any special skills. In other cases, it's a little bit different. When the patient is diagnosed, there are multiple, even though myeloma is considered like, a disease where the cancer cells are copies of each other. And so they're supposed to be, clones of each other. They're not completely all alike. Some of them are a little bit more susceptible to certain drugs, some of them are a little bit more resistant. And then, so some patients, when they relapse, is not necessarily because they gained a new chromosomal abnormality, but maybe it's because that more resistant clone has had the chance to grow up over time. Yeah, exactly. So it's different for different patients. So to answer your question, yes, it is true. Gain of some new abnormalities chromosomally is the reason for relapse in some patients, but not all.
Okay, great. So Stan, did you have any chromosomal abnormalities in your myeloma?
Yeah, I do, but I don't understand them.
Somebody's not doing a good job educating.
I'm totally okay with getting everything from my blood work. But Donna knows my history. She could probably explain it better than myself. I do know there are some good ones and some bad ones, and some of the bad ones are no longer that bad. I know things have changed in the last 6 or 7 years, but to be honest, that's just about all I know.
Okay, all right, Donna, time to spill the beans.
Right, so just let me, Stan, don't feel bad.
No,
because cytogenetics, it's so complex. I know clinicians that don't even understand the nuances of the different abnormalities. So, in Stan's case, and for patients in general, there are some key things you need to ask. So I don't expect any patient to rattle off all their cytogenetics because we could be here until next week. So the first question is, do I have extra copies of chromosomes or am I missing parts of other chromosomes? So Stan, in your case, you actually have multiple copies of whole chromosomes. And, this really is like standard risk. This doesn't place you at high risk. Certain deletions. So Stan, we were talking about, you are missing one of your chromosomes 13, which back in the day may have been considered high risk, but we know that we can target this with proteasome inhibitors. So that might be a reason why we would add Velcade or Kyprolis. So some genetics that we once considered high risk, we can kind of target them now. And then another high risk feature was a 1q amplification. However, in your case, you had one copy, and this was an isolated, it wasn't in combination with other high risk features. So I would consider you overall to be standard risk, if not favorable risk. So you really, we call like double hit, high risk cytogenetics, but really that one isolated abnormality would not put you at high risk. So in general for patients, again, asking, do I have extra copies? Do I have deletions? And what does that mean? Does that put me at higher risk for relapse, or does that make more of a standard risk? Another question is about translocation. So Dr. Wong was alluding to, there might be, there's a certain translocation where it's what I like to call druggable, that we can target it. So translocation is with a chromosome, one arm of a chromosome is swapping another arm of a chromosome. So certain translocations can place a patient at high risk, but other translocations such as 1114, we can consider adding Venetoclax into a patient's regimen, as we know that it targets against that. But that being said, Venetoclax is not FDA approved and it would be given off label.
And I just want to add that, Stan, don't feel bad at all. It is so complicated. It's even complicated for myeloma, docs. And so no worries at all. And I encourage.
No, I when I'm at the doctor's office and he's speaking to the nurse practitioner and I'm in the middle, it's like I'm in a tennis match, going back and forth.
Or they're like basically speaking French to you.
And then I go, is that good? Is that bad?
That's great. That's great communication with the healthcare team. I like that. So,
but I think that really highlights the point that I would ask patients who are listening, don't try to interpret it but yourself. This is so too much nuance, and make sure you rope in a myeloma doc to really interpret it for you. And Donna is absolutely right. So the point about the amplification 1q or gain 1q, or basically changes in the chromosome 1q, is actually very complicated, because there is gain 1q and then there's amplification 1q, and then the semantics and the definition sometimes is a little bit vague, so this is kind of like and some of this is also emerging data as well, with that 1q, if you have, so obviously, normal cells have 2 copies of every chromosome, right? One from mom, one from dad. If you have a extra copy, that is considered a gain of one in that arm, 1q, that's considered gain. And then if you have 2 additional copies, that's amplification. So so just, it's complicated. I would ask, make sure you rope in your myeloma doctor to help you interpret. Yeah.
Yeah, and I'll just add, I think the questions to ask your provider is that, do you consider me high risk? Do you consider me standard risk? So high risk, we want to, we might change the way we maintain you, or really aggressively monitor you. So it's just how we watch your myeloma. So I think that's really the important question to ask as a patient.
Mm-hmm. So, Sandy, both you and Donna talked about T1114 and how that's a so-called actionable or druggable chromosomal abnormalities. Are there any other chromosomal abnormalities that you would consider to be actionable?
Not really. There are, so an extra layer of complexity is not just checking for chromosomal abnormalities, but actually sequencing the myeloma genes. Mm-hmm. Now, in patients where their options for treatments are dwindling, and there's only very limited options, and let's say they can't get on a clinical trial, I might send their marrow for actually sequencing of their genes to see if there's any mutations in the genes of the myeloma cells. And the reason why I bring that up is that in a very, very small subset of myeloma patients, they may carry mutations that render them susceptible to other non-traditional myeloma drugs, like, for example, MEK inhibitors, things that are actually approved in other types of cancers. Right. So that's something that that could be considered. But I don't want to I don't want to bring people's hopes up too high. Having some of those actionable mutations is very rare, but maybe something that is worthwhile checking if folks are out of options.
Sure. Mm-hmm. Okay, so let's talk now about other treatment options for relapsed patients. So, Sandy, many patients want to know if a transplant given at the time of relapse, whether it's their first transplant or their second transplant, is that a reasonable course of therapy?
Yeah, it's not. So if they haven't gotten a transplant ever and they are fit and eligible for one, it's not only reasonable, it's recommended that they get a stem cell transplant, albeit later in their myeloma journey. There's actually a randomized phase 3 trial looking at that question. It was a partnership between IMF and Dana-Farber, and basically they randomized patients, one arm got their transplant early in their myeloma course. Basically, they got induction and then they went on to get their stem cell transplant. And the other group went on after induction to just get maintenance and waited until their first relapse. And most of those patients in that arm went on to get a late stem cell transplant. And what you see in that study is that the progression-free survival, so the likelihood of being free of or progression-free and alive in the arm for people who got it early, they obviously did better than those who got it that did not do a stem cell transplant early. But the survival, so the likelihood of being dead or alive, it was actually the same in both arms. So the take-home message is, if you for some reason did not get your transplant early, at least on relapse, get your stem cell transplant. So that's something that is pretty clear. However, if you've already gotten a stem cell transplant and you're in relapse, the question about a second stem cell transplant is a more complex and nuanced one. Because and the reason why I say that is, well, what are some of the other options out there? And number one, and number two, how well did you respond to your first stem cell transplant? Obviously, some patients, do not respond well, and with your second transplant, the benefit of your second transplant is only half the time of your first one. So let's say someone only got a year from their first stem cell transplant. Well, it wouldn't make any sense to do a second one.
Okay. So, Stan, let's talk about your case. You opted not to undertake a transplant as part of your initial treatment, but you had your stem cells collected for potential use later, right?
Yep.
So since that time, you relapsed and then you received a triplet drug regimen. And can you tell us a little bit about when or if you might consider having that transplant with those cells that are saved?
I'm not planning on using them at all. Knock wood. I've always asked, from the very beginning, I asked the doctor, am I in the same place, as in complete remission? Am I in the same place now as somebody who had a stem cell transplant? And he said yes. And it was never part of the regimen for me. It's like, it's always in the back pocket. If I needed it, yeah, they're there. But obviously I'm doing pretty good. So it's not even in the plan at all.
Right. So, to me, this really sort of highlights the importance of having really good communication with your care team, right? And making really your goals known to the care team so that you can work together to do what's best for the patient and what's best, to provide the best outcome based on the goals of the patient. So that's really super important.
And actually, I just want to add to that. That's absolutely true. I think I always tell my patients, like, there's a difference between a medical recommendation, what the data shows, and embarking on something like a stem cell transplant is a very personal decision. So I always ask my patients that, first of all, if they're hesitant about stem cell transplant, like, transplant is something that, like, you got to really, really want to do it for us to put you through it, because it really has the benefits to them has to really, outweigh the risks of it. And that kind of that consideration is going to differ from patient to patient. I have some patients who are like, hearing about all that I have to go through, all the risk, all the side effects and the benefit, not worth it to me, and some folks are like, yeah, that's what I want to do. So it's a really it's worthwhile engaging in that conversation with your doc. Yes, this is what the data shows, but that may not be right for that particular patient.
Can I say something also?
Sure, Stan.
I know a few other patients and friends of mine who've had transplants, and then I look around and they're on the same treatment as I am right now. Or they relapse pretty much, after 5 or 6 years like I did. So it's like, really, it's like, it is a choice, but I'm looking at it, it's like, I'm in the same place. So what's the point of the transplant for me anyway?
Right. And myeloma is so different in every patient that, what works well for one person may not work well for another person. Sure. And that's kind of what makes the decision-making process so difficult. But it's really the best thing just to talk it out and, talk to your family, talk to your care team, and just decide what the right path is for you. Right.
I think it scared my wife more than it did me.
It's so true. There is a lot of caregiving needs. You're absolutely right, Stan. Yes.
Yeah. Agreed. So, Donna, what can you tell us about, are there more patients opting to undergo transplant at relapse? Or is there a time when considering a transplant, if you haven't already had one, would there be a time where that would be considered to be too late?
No, I'm going to also quote the study that Dr. Wong was talking about from the French team. I don't think it's ever too late because we know that the overall survival with delayed versus upfront was the same in both groups. We did see that patients who got it earlier on, with first diagnosis, that they had a longer period of time being, we'll say, disease-free or progression-free. But it's always an option. With that being said, more of my patients in my practice are opting to do it up front. For relapse, and I think it's always good to collect stem cells, whether or not you ever get a transplant or not. We can always use those cells later on for patients who have more refractory disease and can't tolerate treatments.
Right.
Give them a little boost. I think it's always smart to collect your cells, and they'll be good for the rest of your life. We store them, and they're there for you if you need them. But now I think, too, we have more options for patients, whereas back in the day we didn't, and we were offering second transplants. We're not doing that so much now because we have exciting new treatment options.
Right. Okay, so looking back at our previous webinar on this topic, the bulk of the questions about treatment options during that program really focused on the B-cell maturation antigen, or BCMA targeted immunotherapies, such as CAR T cells and some other things. So again, to you, Donna, the common question we get now is that we have 2 CAR T therapies that are now approved for myeloma patients. And can you tell us something about what the difference is between these 2 therapies, Abecma and Carvykti, and how would you help a patient choose which one that they would receive?
Okay, so we're very fortunate that we have 2 products on the market. The major difference is that Carvykti has 2 BCMA binding domains, whereas Abecma has 1. There is no head-to-head study between Abecma and Carvykti to show which one is better, or which ones come out at top. But we do have the pivotal clinical trials, which led to FDA approval. So with Abecma, we saw 83% of patients responding to therapy. And again, CAR T is a one-time infusion. So 86% of patients responded to therapy. And the duration of that response was just under a year. So with Carvykti, we saw approximately, I think it was 98% of patients responding to therapy, and the duration of that response is almost 2 years. So we have the individual data. We don't have head-to-head, and I don't think we'll see that head-to-head. But the data is out there, and when it comes to choosing one over the other, unfortunately, I don't think patients will have a choice. There is a very limited supply. So when a slot opens up, whatever is available is what we're offering patients. These are 2 still very good options for patients. It's just it's very limited. We might only get 2 or 3 slots a month, and we're offering what we have.
Right. So Sandy, how easy or how difficult is it for patients to get access to these CAR T therapies? I mean, Donna just talked about a little bit that there just isn't a lot of availability. So what options do patients have if they're, not in line for the 2 or 3 slots that may be available at their center? And what options do they have if they can't get into the line at that point and receive that therapy? What other therapy can they then take if they're at that point?
Yeah, so I would just want to give my viewers a few tips about how to get in line for a therapy like that.
Good. Yeah.
First of all, I would highly encourage I would highly encourage that when you're on your 3rd line therapy, don't wait until you're on your 4th line therapy, because your 4th line may not work. The FDA approval is only for patients who have 4 prior lines of therapy. Don't wait until your 4th line. Once you get to your 3rd line, make sure that you engage with a myeloma doc at one of these centers that offer these types of treatments, so they are aware of what's going on with you, so that they know that, so they can keep tabs on you and kind of put you in the lineup, so that when you do need it, that you have a higher, it's not a guarantee obviously, but you'll have a higher chance of actually getting a slot. One other thing, I think the pitfalls is that, when Abecma first was FDA approved, we got all these requests to be seen, but by then, the patients were just way too sick that even if I had a slot, like I would not be able to safely kind of shepherd a patient through this process. So that's why, because keep in mind, we need to be able to control the
Froze.
Oh no.
We lost Sandy.
So I think what she's saying, maybe I can jump in.
Oh,
So, it takes time to make the cells. So we collect a patient's T cells and they need to be manufactured. I'm sorry, Dr. Wong, you froze.
Sorry, I'm back. Thank you, Donna. Sorry about that.
No, so I'll just finish that one thought. So
Yeah.
we need to make sure a patient doesn't have explosive disease, because it's going to take time for those cells to be manufactured. So it takes the right patient at the right time for this treatment. And I'm sorry, Dr. Wong.
No, thank you so much, Donna. I appreciate it. I'm going to yell at my IT guy later.
I know, right?
He's my husband for the viewers. I'm not a mean person. But anyway, so yeah, no, so thank you so much, Donna. That's exactly it. Make sure you just engage with a myeloma doc early, get in line so they can kind of tee you up when the moment is right. Because when you wait for your fourth line treatment, the response rates with your fourth line treatment, unfortunately, are not great. So, in all likelihood, the fourth line is not going to hold you. So just kind of keep that in mind. Now, that being said, if you find yourself in the position where, I really need a CAR-T, I'm out of options, like, what do I do? First things first, clinical trials. If you are eligible for a clinical trial, you are strong enough and in good shape, that is a very good way to access some of these exciting new treatments in order to get disease control. And the reason why I bring that up is, for example, T-cell engagers. These are off-the-shelf drugs. Off the shelf as in you don't have to wait for things to be made for you. CAR-Ts, you have to wait for the manufacturing to occur. Is one way to gain access to these types of drugs that so far has had a really impressive efficacy readout. If clinical trials is not an option for you, there are other standard options. For example, drugs like selinexor, belantamab, mafodotin. Those are drugs that are FDA approved already and should be discussed with your provider. And obviously, if you are really, you have a lot of disease, you need really some, urgent or emergent control, then yes, high dose chemotherapy could be another option too.
Right. So let's talk a little bit more about, lines of therapy and where you sort of have to be to receive CAR-T. So I know that now patients basically have to go through multiple relapses before they're eligible to receive one of the approved therapies. But certainly there's a number of clinical trials underway where CAR-T is being used in earlier lines of therapy in certain patients. So what can you tell us about that, Sandy? And would you expect a CAR-T to actually maybe work better for a patient if they received it, earlier on in their therapy course?
Yeah, so that's a great question. When a patient is, through multiple lines of therapy, their immune system is more beat up naturally because the drugs that we give the patient also impair the immune system as well. However, we know that even in that population, the response rate is very high, right? A response rate of 98%. You can't get better than 98%. I guess you can do 2% to 100%, right? But it's pretty good. And then the estimated progression-free survival, we're talking about CARVYKTI, is estimated to be around 2 years. Can we do better than 2 years? That's the hope. And traditionally, if you look at myeloma drugs that are first approved in those who are late in their myeloma journey and use them early, the great example is daratumumab, right? If you see that Dara, when it was first FDA approved in that multiply relapsed population, we have to remind ourselves the response rate was only 30%. Right, and Dara is like a wonder drug right now. So and now we move it up into earlier lines of therapy, and we see that it works even better. So the hypothesis is that if we move CAR-T treatment up earlier in a patient's myeloma journey, that maybe we'll have even better results, better efficacy results. However, we don't know that for sure. And that's why the studies are being done. And I would also say the flip side of every treatment is side effects, right? It's safety, right? How safe is it to use this? So on one hand, in an immune system that is pretty beat up, on one hand, yes, like you worry about the efficacy, but in terms of the revving up the immune system, well, revving up, an immune system that's kind of sleepy, the side effects may be okay. But what happens when you put it into someone whose immune system is actually really robust? Will you rev it up like a lot and cause like side effects, and to what degree? So I think that is really what I'm watching for these early CAR-T trials, is what is the safety, what is the side effect profile, and how do we balance that with the efficacy?
Right. So on that note, Donna, let's talk a little bit about CAR-T treatment and some of the things that Sandy was mentioning, side effects, toxicities, things like that. Like, what is the process like, and what can patients sort of expect to go through when they're undergoing this therapy?
Right. So, first we collect the patient's T cells, and they go off and they're manufactured. When the T cells are ready to be infused, we give patients chemotherapy to kill their own T cells, and then we will infuse the T cells, their new T cells. So typically, depending on the product, patients are going to be admitted to the hospital, and depending on the product, we can anticipate that patients may have something called cytokine release syndrome, or CRS. And this is, this can be a serious complication from CAR-T. So it's not, and that's why we monitor patients in the hospital. With that being said, in order for a hospital to administer CAR-T therapy, the nurses, the staff are very familiar with these side effects and know how to adequately treat them and manage them. Because I know when you're reading the side effects, it can actually be quite scary. But I think we're so good at recognizing symptoms and reacting. So what happens in CRS, or cytokine release syndrome, is you have a rapid release of cytokines, and cytokines are immune substances, which can cause a cluster of symptoms such as high fever, low blood pressure, other organ toxicity, difficulty breathing, respiratory distress, which again can all sound very scary to patients. And that's why we like to keep them in an inpatient setting and monitor them. And then when we see someone having a reaction, we have an antidote. We have medication that we use to reverse it. And these are not, these side effects are reversible. So that's important to note. And patients will typically stay in a hospital, not more than 2 weeks. And again, depending on the product, we can anticipate when these reactions would occur. Another complication from CAR-T therapy is what we call neurotoxicity. So again, we're not sure how or why this develops, but neurotoxicity, patients can be confused, difficulty finding words, sleepy, hallucinate. And again, we recognize we're always assessing a patient's neurostatus, and we can treat and reverse the symptoms. And that's why it's so important that patients are monitored carefully. So they're in the hospital for, up to 2 weeks, and then we discharge the patient. But again, we can see late reactions, especially neurotoxicity, that can happen within that first month. And that's why a caregiver is very crucial, because I might not know that I'm having confusion. I had a patient who was unable to name the President of the United States, which might not seem like a big deal, but everyone should know the President of the United States. And it was their caregiver that picked that up. And then we discovered that patient was having some neurotoxicity. So it can be delayed. And that's why it's very crucial that patients are close to the center, the CAR-T infusion center. Other things that we want to monitor once a patient goes home is, there could be potential high risk for infection. So, we ask patients to monitor their temperature, and really we try to support them through that period where they're more vulnerable for infection. So we add on antivirals and antibiotics to help support patients. So even though this is a one-time infusion, there is a lot that is involved. But that being said, patients recover very well from this treatment and can have long periods of time. In the fourth line setting, or patients tend to relapse more quickly, we're seeing patients get deep responses and a long duration of that response. So one infusion without treatment for 2 years is in a fourth line setting is actually a very big deal for us. So I think this is very exciting and great treatment option for patients.
Okay, so that was really informative, and I think it's really important for all patients who are even like considering this therapy to really know exactly what the side effects are before. And again, this is communication with your care team to sort of figure that stuff out. So, so Sandy, we talked about these CAR-Ts as BCMA targeting drugs, and so there's not CAR-T is not the only class of drugs that actually is involved with BCMA. There's a couple of other classes which you did mention. So if a person has CAR-T therapy and it works for a little while and then they relapse off of that, would they be able to take another BCMA targeting therapy and would it work?
Yeah, that's a great question. So theoretically speaking, you can do that. You can go and get another CAR-T, and that actually, there are some anecdotes of patients treated on the clinical trials that have gotten one CAR-T after another CAR-T. In terms of, is it going to work? If it's also a BCMA, like if you have one BCMA targeted CAR-T followed by another BCMA targeted CAR-T, is it going to work? I'm not sure, because I don't think that there's been any formal studies that has shown that. In fact, let's not just talk about CAR-T, like one BCMA targeted agent, followed by another one, like, is it still going to work? We don't really know, because I think it's really early days. We have, obviously have belantamab mafodotin, Abecma, now Carvykti, and it's just all been, and it's been great, right? We've gotten these approved in a relatively short period of time, but it's still very fresh, and that's why we don't know. Now, that being said, Dr. Colin at UPenn did publish a report where he had two patients, one who had who got belantamab mafodotin, responded, and then got a BCMA-directed CAR-T and responded.
Wow.
I mean, relapsed and then got the BCMA-directed CAR-T and responded. And then vice versa, he had another patient that did exactly the opposite, and the patient responded to belantamab mafodotin. So, we know that it is possible, but I can't cite any percentages because we just don't know. I think the reason why we don't know, besides the lack of kind of clinical studies, is that we really don't know what is the mechanism of resistance to belantamab mafodotin. What is the mechanism of resistance to CAR-T therapy? What we do know for CAR-T therapy is that there are some reports of patients that relapse after BCMA-directed CAR-T therapy, and then they looked at the myeloma expression of the target, which is the BCMA, and in some of these studies, they showed that that the target is decreased, and maybe that's why patients are relapsing. But then again, that may not be true for every patient. Some patients, I think, simply for some reason, just lose their CAR-T cells, they just disappear. And some patients have CAR-T cells still floating around, they still have the target on their myeloma cells, but for some reason, the immune system, they're sleepy, they're not doing the job that they need to do. So I think, it's biologically, scientifically, it's a very interesting question, but we just don't know the answer. However, logistically, that's a barrier, right? If there's already so few slots for Abecma and so few slots for Carvykti, it is difficult off of a clinical trial to get one after another.
Yeah, right. So I agree that I think that it's definitely early days, and we need more data to actually show that if you've taken a BCMA targeted agent and you've relapsed off of that a second one will not work. Certainly, I have seen some data to the contrary in a few small studies, and the agents that seem to be most effective in this study, which I believe came out of Mount Sinai, but I'm not sure, was actually bispecifics that were BCMA targeted, right? And they did have some interesting responses. So the title of that talk, There is Life After CAR-T. So I think that data will be forthcoming as more studies are being done. But talking again about CAR-Ts that are targeted to BCMAs, are there other CAR-Ts that are targeted to different targets on myeloma cells, which actually could be used if the BCMA targeting CAR-T not working? Sandy?
Yes, actually, there are like a number of targets being studied. I think the other target is GPRC5D. There are people are developing CAR-Ts to that. There's also other targets like CD138, which is another target on myeloma cells. There's also SLAMF7. This is actually the same target as elotuzumab, actually, which is another myeloma FDA-approved drug. And there's also CD38. There's like a number of them that are being studied right now.
So again, more potential choices. So that's always good. So we have definitely heard from patients who either had CAR-T therapy, which worked for a period of time and then relapsed off of it, or had CAR-T therapy, which actually they were refractory to and it really didn't work. So if you were in that class of patients, what other options do you have if you've relapsed off of CAR-T therapy or if it's just not working for you? There are other classes of agents, right, Sandy?
Yeah. So like the T-cell engagers, not yet FDA approved yet, but available on a clinical trial. These are drugs that you don't have to wait for something to be manufactured. They take them off the shelf. What T-cell engagers are, they're basically antibody-based drugs. They have two arms. One attaches to the myeloma cells. The other one attaches to your T cells, and then brings them together and say, and basically it gets your immune system, in close contact with your myeloma cells, and your immune system is like, wait a sec, you're not supposed to be here, and gets rid of them. So there are a number of T-cell engagers in clinical trials. I think the hottest one right now is teclistamab, but followed very closely by arinatamab. There's also anuctamab. There's one from AbbVie as well. This is a whole list of them that being developed. So really exciting times.
Yes.
And then we talked about different targets with CAR-Ts. Well, same thing for T-cell engagers. They're also studying T-cell engagers against the target GPRC5D, and that's talquetamab. We've seen that presented at ASH meetings. In general, this entire class of drugs, the general response rate has been around 70-ish% or so. So not as high as, like, for example, Carvykti, but obviously remind you with Abecma, the response rate was in kind of that ballpark too. So, between a CAR-T that you have to wait to get versus one you can get like right now, obviously the T-cell engagers would win in that respect. But obviously the downside is that, CAR-Ts is kind of like a one and done deal. And obviously T-cell engagers, you have to go back and again and again to the clinic to get it. So that's one class of drugs. We talked about selinexor. We talked about belantamab mafodotin, other drugs that you can use in this multiple relapse setting for the treatment of this disease.
Yeah. And there's also what they call the iberdomide, right? Which is sort of like a next generation immunomodulatory drug, sort of along the same lines as like Revlimid or Pomalyst. And that is not yet approved, yes, but it could be used by patients in that setting as well, right?
Exactly, on a clinical trial, exactly.
Okay. Okay, so I think we're getting toward the top of the hour a little bit. So I have a really interesting question, actually, that was asked by one of the patients on the webinar a couple of weeks ago. So I'm going to ask this question, and we can everybody on the call can respond. So the question is, if a patient relapses, their myeloma comes back, it seems really important for a patient to not only talk to their own care team, but perhaps get a second or maybe even a third opinion from other clinicians as far as what might be appropriate for them to take at this time. So if you are this patient and you talk to your own doctor and they suggest a certain therapy course, and then you would go, maybe they would suggest, why don't you go talk to Dr. Y and see what Dr. Y has to say about this? So you would go to that doctor, and then you would go to Dr. Z and then see what Dr. Z, would suggest. So if you have this experience and actually you get three different choices of where you could go at this point in your therapy, what's the best way to sort of decide which way to go? And Stan, I'm going to put this question to you first. Has that ever happened to you? And if it did, how would you manage that?
I'm not quite sure. I mean, living in New York City, I have lots of choices, obviously, where I can go. I'm perfectly happy where I am. The team at Mount Sinai is great,
Mhm.
and Dr. Jagannath is great. And sometimes I'll push a little, but then I always defer to him. So,
Yeah. So, I mean, if you
and
trust your care team, then that's a good choice, right?
yeah, I don't know how you would choose if one doctor saying we do this and another doctor is saying we do that.
Mhm.
It's also a matter of how you feel with the doctor personally.
Sure.
I don't know how to answer that otherwise. It's how
Mhm.
the interactions.
Yeah. No, I agreed. Donna, have you seen that type of situation or scenario sort of come up in the clinic, and how did the care team and the patient manage that?
Yeah, so as Stan was saying, New York City, you can go 10 blocks and get a second opinion. So my advice is knowledge is power. So,
Mhm.
Ask the questions, if someone is recommending a regimen, what was the overall response rate to this regimen? How long did patients get? What was the duration of response? So educating yourself on the regimen, how patients benefit from it. Also, ask what the side effects are. If you already have pre-existing neuropathy, you probably want to really think about, do you want to have another drug that might cause neuropathy? So what are the side effects? And then what are your goals of therapy? So what's the regimen like? How often am I coming into the clinic to get an infusion or injection? Does that align with your goals? And then you have to make that decision, but really get all the knowledge you can so you can make a very informed decision.
Right. Oh, all really good points. Sandy, how would you handle that?
It's funny that you asked that, because that has been definitely something that's come to the forefront in the midst of this pandemic, because
Mhm.
now that we have virtual health and people can seek opinions versus virtually, this has actually come up several times for me. And I think for me, what I've learned from this experience and what I can tell our viewers is that I think ultimately, so first of all, if you have 3 myeloma docs that render 3 different opinions, we're probably talking about a scenario that has a lot of gray, and where there's not much data to really tell you should do one thing or another thing. And that's why you got 3 different opinions, right? And I think it's really important to ask each person who rendered the opinion, one, what's the risks and what's the benefits of each of these, and what's the risk and what's the benefits? Is there data? And if there's no data, where is this recommendation coming from in the absence of data? And to have them explain their rationale for why they're making this recommendation, in the absence of data. And sometimes it's not because
Oh, that IT guy, he's going to catch us.
He's fired.
Okay, moving along.
Maybe I can jump in.
Go ahead, Donna. Go ahead.
Because there's no standard approach to relapse. I think that's what Dr. Wong was saying. You might get 3 different opinions, because if there was a standard approach, everyone would be getting the same thing at each time point.
Right.
So I'm sorry, Dr. Wong, you froze again.
Sorry about that again. Thank you, Donna. You're my lifesaver.
Finish your thought, Dr. Wong.
No, I want you to finish your thought.
So I think what you were saying, I was just talking about, there's no standard to relapse. And really that's why there are so many approaches to how we might manage a certain patient, and asking why would you want me on this regimen? I think that's maybe where the direction you were going.
Yes, you're absolutely right. And so I think, so every opinion you render, I would say, don't be a passive kind of receiver of that opinion. Ask these active questions. Be like, hey, what is this really buying me? What is this regimen really buying me? And what's the price for it? And so that you understand what you're getting into, so that you can make an informed decision. And then after that's done, I think the patient does have to look inwards. And I completely agree with Donna. The patient has to ask themselves, what are they willing to put up with? For what gain, right? Very recently, I rendered an opinion, and then there was another opinion from a different myeloma doc, and the patient was like, you know what, I really don't want to be in the hospital for that period of time. That's kind of kind of like a deal breaker for me. And so we're like, okay, that those are your values.
Yeah,
Then we
right.
need to take that into account when we select what we do next. So I think, understanding what you want, what your own values are as a patient is very important.
Yeah, no, that's totally true. Totally true. So, so I think we're close to the end of the hour, but I just wanted to summarize a little bit. So just after our discussion today, with all three of you, and thank you so much for being here. I think that really the takeaways are, first of all, that if you are a person who's in this position where you've had a number of lines of therapy and you relapsed yet again, there are still some very viable and very effective choices for patients. So that's good. The second point is how important it is to empower yourself with knowledge about what your choices are, what the risk benefit ratio is of these things, what the side effects are like, and most importantly, what your goals are of therapy, so that you can make informed decisions of what you want to do next with your care team. And again, like the really the biggest point is communication, right? It's really so important for patients to speak with their care teams, get second opinions, and then really educate themselves so that they can really make the best decisions in collaboration with the care team based on their goals. So communication is really very important. So thanks everybody for being here for the last hour or so. On behalf of the MMRF, I'd like to thank Dr. Sandy Wong. I'd like to thank Donna Catamero and also our patient Stan for being with us today for the hour. I'd like to thank all of our viewers for taking time out of your day to watch our session. I would like everybody who's watching, if you could, to please go into the comment section of our program, and you can please complete our brief evaluation, and there's a survey link posted in the comment section. So if you just go there and give it a quick click, we'd love to hear your comments, and this is how we make these programs better so that we can basically provide what you need as patients and really help the best we can. And finally, I'd like to thank our sponsors of this program, Adaptive Biotechnologies, Genentech, Janssen, Karyopharm, and Takeda. If you have additional questions around what we talked about today, or really any additional questions about myeloma in general, please don't hesitate to contact our MMRF Patient Navigation Center, and their phone number is 1-888-841-6673. Our navigation center is staffed by very knowledgeable myeloma professionals who can help you with any questions. So once again, thanks so much everybody for being with us today, and have a great rest of your day.